Good morning, everyone, and this is the second lecture for nephrology. And in this lecture, we are going to start with proteinuria because the last lecture, we left at this point. We were discussing what is azotemia and what are the causes. So, proteinuria, simply proteinuria means what? That protein started appearing in the urine, and um, it's not started appearing, it's excess of proteins in the urine because there is a small amount of proteins in healthy people, and of course whenever there is more proteins coming in the urine, which means that there is some pathology. So uh, clinically, like when we take history, we ask the patients if they have mm, um, foam formation, white color of foam formation in the toilet where they urinate, because if there is foam formation, it means like there is proteinuria. So not so specific, but a helpful point. Um, Now, proteinuria is can point towards different conditions. Okay, and the standard test which we can do is called as 24-hour urinary protein. This is the gold standard to assess degree of proteinuria. Like you have to collect the protein, the urine for the 24 hours, and then you will see how many proteins are there. Of course, like a long procedure, right? In the previous lecture, when we were studying multiple myeloma, if you remember, there was proteinuria in multiple myeloma as well, right? So one of the thing is that urine dipstick can also tell that, which is the office test, by the way. And when we dip that stick, and if there is proteins, like excess protein in the urine, we can say that the patient have proteinuria. So of course this is the gold standard, but of course it needs 24 hours of urine collection. So hospital setup it is possible, or of course like otherwise the patient have to collect the urine for 24 hours. Quite hard. The second one is urine albumin to creatinine ratio, ACR, a very quick and very good test to check for proteinuria. Okay, what is this ratio? This one is very good to as a screening test for diabetic nephropathy. In diabetic people, what happens is that there is uh, presence of proteins in the urine, or microalbumin urea can be there. So this one is very good to check for that. Okay, and what they do is like it's a ratio from like albumin to creatinine. Okay, and of course like whenever the albumin levels are increased in the urine, so it means like more and more protein the person is losing in the urine, right? So like we can take just one sample of the urine, we can spot check that sample, compare the level of albumin in the sample against the creatinine. Okay, so quite easy. And the thing is that the values for the males and females is different. Why? Because the males have more muscle mass and the females have less muscle mass. This is the reason, like they have different values for males and females. So what is done is like we ask the patient to take an early morning sample of urine, and then we check that thing. But one of a very important thing, that if you will keep on standing for a long time, or you will exercise too much, there is more proteins in normal person and healthy people I'm talking about. So of course like make sure before doing this test that the person should not have done any exercise in the last 24 hours at least. So Whenever there is a proteinuria, the ACR levels will be raised. You can see microalbuminuria is defined as when albumin to creatinine ratio is more than 2.8 in females or more than 2.0 in males. Okay, so of course, like because male have more muscle mass, or males have more creatinine. It's also a marker of vascular endothelial function, an important prognostic marker for kidney disease and diabetes and hypertension. And elevated ACR is the earliest sign of diabetic nephropathy. Very important point. This ACR can guide us very quickly towards diabetic nephropathy. Composition of normal total urine protein, if you will see, upper limit of normal daily excretion. See, now remember, albumin is also a protein, but here they are talking about the total protein. Here they are talking about the total protein, like the normal upper limit of daily excretion of the total protein is 150 milligram per day, whereas the normal limit of normal daily excretion of albumin is 30 milligram per day, right? So 150 is total protein and albumin is 30 milligram. So remember, if someone is losing like 15 milligram per day, that's not albuminuria. Anyone who will lose more than 30 will be called as albuminuria, right? Or if someone is losing more than 150 total proteins, then it will be called as proteinuria. The other normally excreted proteins are either filtered low molecular weight proteins like immunoglobulins, light chains, or beta 2 microglobulins, or proteins secreted by tubular epithelial cells. They are called as TAM, horsefall, mucoprotein. Very good. Like the previous lectures were about multiple myeloma. So in multiple myeloma, if you remember, there is light chains, which started appearing in the urine. There is Benz-Jones proteins as well. Okay. So albumin is formed by liver, by the way all the proteins are formed by the liver. Okay. And the important thing is that like even immunoglobulins are proteins. Concentration of the albumin in the urine is one of a very sensitive indicator of kidney disease, particularly in diabetes and hypertension. Okay, as a loss of proteins from the body is more and more and more, of course, there will be a time that we are going to see the symptoms in the persons, right? So this is very important thing. So I told you prolonged standing, heavy exercise, different conditions like diabetic nephropathy, hypertensive nephropathy, multiple myeloma, nephrotic syndrome, eclampsia, preeclampsia. There are many conditions in which what will happen, there will be proteins in the urine. Okay. So of course the problem can be the glomerulus. Okay, the problem may be like increased level of proteins in the serum, or the problem can be like the proximal tubules cannot absorb the proteins back. That is called as Fanconi syndrome. Now, what are the causes of proteinuria? There is physiological proteinuria, there is pathological proteinuria. Physiologic, as I told you, prolonged standing, orthostatic, okay, and transient in fever, in congestive heart failure, or in exercise, okay. These are the physiological causes. There is protein in the urine, but it's normal. There is no disease in the kidneys, right? Pathological causes are there. In pathological, of course, there is one is tubulointerstitial disease, one is glomerular disease, one is overflow. That's what I'm saying. Either in the blood there is a lot of proteins, either there is some glomerulus disease, like the proteins are filtering out, or either there is tubular interstitial disease in which there is impaired resorption. So if you can see over here, whenever there is tubular interstitial disease, there is impaired resorption. But the protein level is less than 2 gram per day, and I gave you the example of Fanconi syndrome already. The other one we just now finished studying, topic called as multiple myeloma. If you can see over here, or Waldenstrom macroglobulinemia or amyloidosis. So what happens? See, there is overproduction of low molecular weight proteins, light chains, kappa and lambda, which I already talked about. And one of the causes glomerular, of course, like when there is some glomerular disease, so there is loss of large sized proteins in the blood. So glomerular diseases can be many types. If I will tell the names now, of course, you won't understand. Of course, we are going to study them. There are primary conditions, there are secondary conditions, which are secondary to certain other conditions. Primary conditions like minimal change disease, or you can say minimal change glomerulonephritis, membranous focal segmental glomerulosclerosis, membranoproliferative, post-streptococcal glomerulonephritis. This thing you already covered in pediatrics. IgA nephropathy, already covered in pediatrics. And it could be secondary to many things like NSAIDs use, cancers, hereditary causes, infectious diseases, systemic diseases. Okay. So see, when the total protein is less than 150 or the albumin level is less than 30, I already told you that is considered as normal. When the level of albumin, see, there's two things I'm talking about, total protein and albumin. When the level of albumin is less than 300 but more than 30, so we call it as microalbuminuria, which happens in kidney in diabetic nephropathy. When the level of total protein exceeds 3.5 grams, or you can say 3500 milligrams per day, we call this thing as nephrotic range proteinuria. Okay, so up to 2000 milligram per day of protein loss is possible with tubular diseases because of failure to reabsorb filtered proteins like these causes. And there is variable amount of proteinuria can be seen with glomerular diseases, right? So we'll discuss all these things, of course, in the coming days, of course. So what investigations we can do whenever there's any proteinuria? We can do urine examination, culture and sensitivity, urea and creatinine. So what we are doing, we are looking for any urine infection, urine microscopy. We are doing all this test, and we are doing urea and creatinine to check the kidney functions. And further workup if degree of proteinuria is greater than 0.5 gram per day, or there is cast or hematuria is there. Hematuria means blood in the urine. Then we go for CBC, glucose, electrolytes, 24-hour urine protein, creatinine, urine and serum immunoelectrophoresis. I'm sure like now you can understand what is this thing. Again, in multiple myeloma, I talk about SPEP and UPEP. We can do abdominal pelvic ultrasound as well. Now, this is something which you won't maybe understand right now, but these are different things like anti-neutrophilic antibodies or rheumatoid factor or cytoplasmic antibodies. So all these things are basically connected with connective tissue diseases, or you can say rheumatological diseases, which we are going to cover in rheumatology. So anyone who have generally, heavy proteinuria, we refer them to the nephrology. And heavy proteinuria is anything when the ACR is greater than 30 milligram per millimole. Definitely if there is nephrotic syndrome. So I think one thing which you understand about nephrotic syndrome is what, like when the protein loss is more than 3.5 gram per day or 3500 milligram per day. Guys, I already talked about nephrotic syndrome during pediatrics. So pathological proteinuria, like this is what you can say, tubular interstitial, glomerular, or overflow. So normally you see low molecular weight proteins which are less than 60. They pass through the glomerular filtration barrier. All the proteins have the negative charge, remember this thing. But they are reabsorbed in proximal tubules. So when there is proximal tubule dysfunction, of course, like that, they cannot reabsorb and they started appearing in the urine. So I gave you the example of this condition, Fanconi syndrome is there. So as albumin is greater than 60, so that's why, albumin is not filtered because it is bigger. Glomerular causes normally see their filtration barriers selectively permeable to size, again less than 60, and charge, the negative one. This albumin is filtered to a very limited extent. And whenever there is damage to the glomerulus, we call this thing as glomerular diseases. And when we are going to study glomerulonephritis, I'm sure many of you will be confused. Like that's why you have to develop good concepts about the signs and symptoms. So in this one, we are going to lose a lot of proteins. And that's why in many of the glomerular conditions, the patients, they develop edema. Why? Due to hypoalbuminemia, decreased albumin in the blood. And then there is overflow one. Again, multiple myeloma and all these conditions in which there is formation of too much uh, proteins are there. Proliferation of monoclonal cells, proteins, of course, they will start appearing in the urine. So that's all about proteinuria. So we have done azotemia, we have done proteinuria, and now we will move on one more thing that is called as hematuria. So hematuria means what? Hematuria means hematuria, or hematuria means blood in the urine. Presence of RBCs in urine. Now there are two types, gross one and microscopic one. When you can see that the urine color is red by your naked eye, though there are certain other causes of being the urine which can impart the urine red color other than blood causes, but simply presence of blood or RBCs which you can see by your naked eye is called as gross hematuria. But when you cannot see by your naked eye, but microscopically they can found that there is RBCs in the urine, it is called as microscopic hematuria. So if the sediment is red, it is true hematuria. If the supranatant is red, test for heme with a dipstick, urine dipstick. I will talk about urine dipstick, what it is in a while. Okay. So anyone, like whenever we found 2 to 3 RBCs, or like on microscopy, we call it as microscopic hematuria. So now the causes of hematuria. So here it is written red urine because uh, there are other causes of having red urine as well. So whenever we have to check for blood in the urine, what we do, we can do an office test called as urine dipstick test or test strip, which is office test. The GPs have that thing in their office, and what happens is like we can simply dip the stick in the urine, and in the next lecture I will tell you like what that dipstick can tell you. So see, there can be three causes. Number one, the dipstick is negative and there is no RBCs. Okay, which means the dipstick shows no blood, and when you check it with the microscope, there is no RBCs, but that urine was red. The other thing which can happen is like the dipstick was positive, and when you see it under the microscope, you found the RBCs as well, which is basically the true hematuria, right? And the third condition is when the dipstick was positive, but when you see under the microscope, there is no RBCs, right? So when the dipstick was negative, and when you see under the microscope, you did not find any RBCs, it is called as pseudohematuria. Many foods like beets, dyes which they use in coloring, uh, the as a coloring agents, and medications. Again, if you remember, one of the anti-tuberculosis drug, rifampicin, which I told you, it gives orange color or orange pinkish color to the body fluids. It can change the color of the urine as well. These are the causes. When the dipstick was positive, but there is no RBCs, remember it could be myoglobin in the urine, which can be the result of um, damage to the muscles. Myoglobin will be released and started appearing in the urine. The true hematuria, when the hemoglobin, like the dipstick is positive as well as the RBCs are also present. True hematuria. Hemoglobin is there. There are three causes. Number one, there could be a problem in the blood, like coagulopathy or sickle cell disease, by which like the RBCs are started producing and appearing in the urine. For example, the person is taking some anticoagulant, or what we can say blood thinning medications. So that's the reason like the cells are started appearing in the urine. Second one is urological causes. Urological causes are those guys like simply uh, if there is a tumor, if there is trauma, if there is infection, if there is any manipulation or iatrogenic causes of anywhere in the urinary tract, like in the ureters, in the bladder, in the prostate, in males, or in the urethra, any tumor, infection, trauma at these places or inflammations can lead to bleeding. And see this one, stones can cause damage the urinary tract, nephrolithiasis, trauma, tumor, prostatitis, urethritis, and dysuria or flank pain is common. And one of the things, whenever they see the urine under microscope, they see that either the RBCs are intact or broken. If the RBCs are intact, it means there could be all these reasons. But if the RBCs are broken, like cast, we call it as cast cells. If the cast cells are present, then of course it means broken RBCs, which means they are broken down when passing through the glomerulus, right? So we don't see cast cells in these causes. Okay. So on the history, by the way, one very important thing, we always ask like either the blood come in the start of the urination, at the end of the urination, or either the blood is completely mixed with the urine. A very important, a helpful type of thing, which we ask on the history. So if the bleeding is at the start, it could be urethritis. The bleeding can be from the urethra. If the bleeding is at the end, It means the source can be bladder or the prostate. Very, very, very important, helpful point in history to differentiate the causes. Third thing is renal causes. Again, we are not going to go in detail because we are going to study all these conditions. There could be primary conditions, glomerular condition, or secondary, which are secondary to other conditions. So primary are again the same things which we study in proteinuria. You can see over here, same diseases, and even in hematuria they are the same diseases. And secondary are almost same. You can see hereditary Alport polycystic kidney disease. You can see hereditary Alport polycystic kidney disease. You can see over here connective tissue disease like SLE, good pastures, Wegener's, Chwag-Strauss, okay. HSP, Hinox-Colleen purpura. We already covered this thing. In pediatrics, you will see the same condition here, SLE, okay. So you will see the same conditions here, same condition there, same condition there, same conditions there, almost the same conditions. So what are the investigations? Whenever there is anyone who comes with hematuria, see, first of all, we take the history, okay. So in history, we ask about the family history of stones, hearing loss in Alport syndrome, cerebral aneurysms to check for polycystic kidney disease. We ask for the diet, beetroots, any other dye containing diets, recent upper respiratory tract infection to check for HSP, irritative and obstructive urinary symptoms to check for UTI, prostatitis, prostate, all these things. So see, like, of course, I did not talk about the complete history. If someone have hematuria, the first question you will ask, when started, how it is progressing, either it is coming as a mixed form, either it is coming at the start, either it is coming at the end, and questions like this you will ask, right? So then we'll do the urine examination, culture and sensitivity, urea and creatinine. Simply, guys, this is the baseline test in nephrology. You are in nephrology, right? To check for the kidney anatomy of the structure, we can go for renal ultrasound. We can do each 24-hour urine stone workup to catch any stone. Nowadays, we don't do this thing because CT scan and all these investigations help us a lot. If there is a history of stone formation or if there is stone noted on imaging, calcium oxalate, citrate, magnesium, uric acid, or cysteine, we will go for further workup. If casts are there, what I told you, glomerular sources there, or proteinuria. We will go for CBC electrolytes and again serology, which I told you in rheumatology you will understand. And we will consult the urologist to do cystoscopy. Cystoscopy, they are going to look all inside the urethra, all inside the bladder to catch the source of the hematuria, right? So this is about proteinuria and hematuria. Okay. So so I think in the next lecture I will be talking about the rest of the investigations, right? I hope you understand this thing. This azotemia, proteinuria, and hematuria are very, very, very important things. Okay.